Powell?
And I just wanted to emphasize a couple of things about the governance structure. When we talked about a governance structure, it was governance of the financing, not governance of GME. And I think it's important to make that distinction. We recognize that the changes that we were suggesting, moving from a very formulaic system to a system that was much more complex and involved these two funds that we've discussed, would require oversight and would also require a body to actually come up with not only a strategic plan, but some of the ideas for the pilots that Deb just mentioned. So we recognize that the accreditation agencies, both osteopathic and allopathic, now coming together, do not oversee financing, are not involved in financing, and cannot be involved in financing because of very numerous antitrust issues and other issues. So this new policy council was really to oversee the financing, as was the operations center. And we discussed a variety of different options for this. We talked first about expanding COGME, which is currently in HRSA, and we talked about COGME on steroids. But because it is in HRSA, because it is not well-funded, and because it is by statute stakeholder represented, we thought that this was not a good option. We talked about expanding MedPAC, but MedPAC oversees all of Medicare, not just GME, and it seemed far too difficult for MedPAC to take on this important piece with the complexity that it was going to have. We talked about a separate GME congressional agency, but that would require new funding. It could not oversee Medicare fund distributions, and that did not make sense to us. We talked about a public-private advisory group, but that would require a private champion to partner with a public champion, and also would require a new funding stream. So ultimately the committee came down to the idea that it was best to put this new governance structure of the financing in the agency that was most closely associated with the financing, and create the policy council at a very high level, the office of the secretary, and then the operations center, which would actually deal with the funding issues of these various pilots as well as the PRA down in CMS where the money actually was. But we gave a great deal of thought to this. We also thought that the policy council should be small, should be term limited, should not represent the majority of representation being from stakeholders, but being from expertise, such as workforce expertise, healthcare financing expertise, healthcare education expertise, and that it should consist of also ex officio members from important interested parties, such as the VA, the Department of Defense, and a representative from the accreditation community. So that was our rationale. I'll stop there.